Hi, my name is Ravi Nistala, and I am from the University of Missouri, Columbia, and I have been given the opportunity to present as a finalist at the Harry Goldblatt New Investigator Symposium, and it is my pleasure to be here, and I thank the organizers for selecting me as a finalist. Um, the topic I'll be presenting today is the role of DPP4 inhibition um, in improving angiotensin II-mediated inflammation in kidney injury. We got interested in the DPP4 inhibition and angiotensin II crosstalk because primarily we are a renin-angiotensin system lab, and we had the opportunity to work with this DPP4 compound, and that got us started initially. The topic of today's talk is more about saxagliptin, and it is an approved drug for diabetic patients. It is one of the many approved drugs, and it has a very nice safety profile. And not a whole lot is known about its role in immune regulation. However, preliminary work from our lab showed that the DPP4 inhibition was preventing angiotensin II-mediated activation of AT1 receptor in proximal tubule cells. It was almost like it was a partial AT1R inhibition. It was so powerful because it was inhibiting the activation of mTOR, S6K, and ERK1 and 2, which are all known downstream signaling molecules that are activated by AT1 receptor activation. So having seen that, and we also saw that DPP4 inhibition was preventing the downregulation of megalin, which is a receptor endocytosis protein in the proximal tubules. So downregulation of megalin prevents the uptake of albumin. So by preventing the downregulation, the uptake of albumin was restored. So having seen this data, we designed a study where saxagliptin was administered a week after angiotensin II infusion was started in mice aged about 10 weeks. So angiotensin II was continued for 3 weeks at a dose of 1,000 nanogram per kilogram per minute, which is a pretty high dose. And saxagliptin was started at a dose of 10 milligram per kilogram a week after angiotensin II. So it was a treatment kind of paradigm. We wanted to see what effects of angiotensin II saxagliptin can actually reverse. So what we found was we found that angiotensin II appropriately increased blood pressure, and it also led to proteinuria and albuminuria. Saxagliptin did not reverse the blood pressure elevation, nor did it fix the proteinuria at that dose and at that time point. But we did look at the kidney injury portion, and what it showed was Ang2, as expected, caused mesangial expansion. The mesangial expansion was patchy, and this is quite well known because the C57 mice is a little bit resistant to renal injury. So as expected, we did see patchy mesangial expansion. We did not see a whole lot of podocyte effacement, but we did see, again, patchy tubular injury, proximal tubular brush border injury. And this was corroborated with loss of megalin. And saxagliptin treatment improved megalin expression in the brush border. Again, we did a flow sorting to look at the inflammation more closely in the kidney, and it revealed that Ang2 activated the memory type population, the CD44 highs, CD62 low, and it also led to increased expression of CD26 on the CD4 subset of the T lymphocytes. So saxagliptin treatment mitigated both these effects. in essence, although proteinuria wasn't improved, there was improvement in the inflammation, and there was improvement in some of the histology, um, particularly the mesangial and the proximal tubular markers. We concluded that saxagliptin, although it did not prevent or reverse angiotensin II-mediated kidney injury and inflammation completely, it did have a substantial reversal of the proximal tubular injury, mesangial expansion, and some of the inflammatory markers. Right now, we are also continuing this trial with a lower dose of angiotensin II, which is more physiological, and it does raise blood pressure. And what we have seen on the preliminary results so far is that there is a reduction in proteinuria in this case, and there is an improvement in albuminuria as well, along with improvement in DPP-4 activity. So we're obviously planning on looking at more of the inflammation and kidney injury markers, but it's for future studies. The translational relevance of DPP-4 inhibition is related to the elevation or activation of the renin-angiotensin system in hypertensive patients and obese patients and diabetics. We have also seen that, and others have shown that there is elevated DPP-4 expression and activity in type 2 diabetes patients, type 1 diabetes patients. We have seen it in rodent models of diet-induced obesity and genetic models like Zucker diabetic. So since there is an activation of the renin-angiotensin system, and which is very well known, and there is a elevation of DPP-4 activity, it is important that a drug which is effective for diabetic patients is able to regulate or modulate the renin-angiotensin system, which is obviously elevated in these conditions. Definitely, the DPP-4 inhibition adds further to our ability to modulate the progression, maybe even the incidence of insulin resistance and diabetes and hypertension and cardiovascular disease. I want to thank the organizers and Dr. Wilcox and the high blood pressure selection committee for selecting my talk and giving me the opportunity to present it.